A 62-year-old male was brought to casualty with sudden onset weakness of the right side of the body and slurring of speech since 2 hours. The onset was sudden, and the patient was normal before this episode. Associated symptoms included facial deviation to the left, difficulty in speaking, and right-sided arm and leg weakness. There was no loss of consciousness, seizure, or trauma. His past history includes hypertension for 10 years, type 2 diabetes, and he is a smoker. He has no previous stroke history. On general examination, the patient was conscious and oriented, afebrile, with no pallor or cyanosis. Vital signs showed BP, 190 over 110 millimeters of mercury, pulse, 84 per minute, RR, 18 per minute, and SpO2, 98% on room air. Neurological examination revealed slurred speech, right UMN facial palsy with forehead spared, and motor system findings of right upper limb power 2 out of 5, right lower limb 3 out of 5. Tone was increased on the right side, reflexes exaggerated on the right, and plantar extensor on the right. Reduced sensation was noted on the right side. The provisional diagnosis is acute stroke, likely left MCA territory involvement. Strokes are primarily categorized into ischemic stroke, which is the most common, and hemorrhagic stroke, which includes intracerebral hemorrhage and subarachnoid hemorrhage. Immediate management in casualty involves ABC stabilization, airway protection, oxygen if SpO2 is less than 94% for access, and checking random blood sugar. A neurological assessment, including calculating the NIHSS score and determining the time of onset, is crucial. Urgent investigations include a non-contrast CT brain to rule out hemorrhage and random blood sugar. Baseline investigations comprise CBC, PT/INR, APTT, RFT, LFT, serum electrolytes, ECG to look for AF, and a chest X-ray. If the CT brain shows no hemorrhage, indicating an acute ischemic stroke, we assess eligibility for thrombolysis. Criteria for thrombolysis include ischemic stroke, symptom onset less than 4.5 hours, blood pressure less than 185 over 110 millimeters of mercury, and no contraindications such as recent surgery or bleeding. The drug used is Alteplase at a dose of 0.9 milligrams per kg with a maximum of 90 milligrams. This is administered as a 10% bolus, followed by a 90% infusion over 60 minutes. If the patient is not eligible for thrombolysis, the plan includes antiplatelet therapy with aspirin 300 milligrams after CT, high-dose atorvastatin, non-aggressive BP control, physio